In this episode of the Nurse Practitioner Podcast, Dr. Julia Rogers and Dr. Manisa Baker discuss 3 central cardiac disorders seen in primary care. What is the significance of understanding pathophysiology of cardiac disorders?
It is important to have a breadth and depth of the pathophysiology of cardiac disorders because they are interwoven on many levels. Cardiovascular disorders are the #1 cause of death annually. Therefore, it is important for nurse practitioners to have a clear understanding of the pathogenesis of each disorder in order to appreciate how the examination and treatment are guided. For example, the pathogenesis of atherosclerosis is initiated through other cardiac disorders. Modifiable risk factors such as hypertension and hyperlipidemia are directly associated with the advent of atherosclerotic cardiovascular disease. These risk factors unite behind a convergence of multiple mechanisms, which involve oxidation and inflammation in the artery wall that with time gives rise to characteristic fatty fibrous lesions that eventually adhere to the arterial wall, causing plaque formation. Physical trauma and inflammation produce lesion rupture, which then leads to clinical events such as heart attacks and strokes. Disease progression is marked by the inflammatory indicators such as the C-reactive protein, which is how the pathophysiology not only leads to a better understanding of cardiac disease, but why certain laboratory tests, such as the CRP just mentioned, and treatments are prescribed. Overall, an understanding of the pathophysiology means appreciating the cascade of events that happens within the body, causing a reactive process to unfold.
The pathophysiology of hyperlipidemia is very complex. It's essential that nurse practitioners understand it so that they can promote cardiovascular health and wellness. The management of hyperlipidemia is important to the prevention of cardiovascular disease. It is a risk factor associated with it. It's important to understand all the components of a lipid profile and how each lipid affects the body. Lipids are necessary for the normal function, and it's important to know which ones to focus on. LDL, for example, is a lipid that we focus on the most because the oxidized LDL causes atherosclerotic plaque. Understanding the pathophysiology helps nurse practitioners understand what and why disease processes develop. Having a good understanding of this will help that nurse practitioner promote prevention and enable them to manage these patients more effectively.
What are the similarities in the pathophysiology of disease processes, and what are the inherent differences between hypertension, hyperlipidemia, and atherosclerosis?
Atherosclerosis is a major cause of cardiovascular disease. Hyperlipidemia and hypertension are the most common risk factors associated with atherosclerosis. The similarities of pathogenesis in these diseases were touched upon earlier by Julia, stating that oxidation, inflammation, and LDL buildup in the artery wall initiate the events leading to atherosclerosis.
There are definitely inherent differences within each of these 3 disease processes. First, let me discuss hypertension. Hypertension is the result of various genetic and environmental factors mediated by neurohormonal effects. The primary intermediaries involved in blood pressure regulation are the sympathetic nervous system, the renin-angiotensin-aldosterone system, and natriuretic peptides. A central component in the pathogenesis of essential hypertension is a shift in the pressure-natriuresis relationship. This means there is increased vascular volume and decreased renal salt excretion. So how does this happen? Well, a shift occurs to a disturbance in one or more of the following intrinsic mechanisms, including the mediators I just mentioned, the SNS and the RAS. But also included is the abnormal release of antidiuretic hormone and autoregulation.
The pathogenesis of atherosclerosis is initiated by an injury to the endothelial cells in arterial walls, which can be caused by hypertension. This triggers an inflammatory response. The chronic inflammation, along with the accumulation of low-density proteins, or the LDL we mentioned earlier, in the arteries will eventually lead to the development of atherosclerotic plaque. Plaque formation leads to a reduction of blood flow in the lumen of the artery. These plaque developments or ruptures can cause acute coronary syndrome, angina, stroke, transischemic attacks, and peripheral vascular disease.
Explain how the clinical manifestations of hypertension, hyperlipidemia, and atherosclerosis relate to each other and are tied to the pathophysiology of the disease.
Many of the clinical manifestations for hypertension, hyperlipidemia, and atherosclerosis are the same, and those signs and symptoms are relatable back to the pathophysiological processes of all cardiac disease. Some of the similarities include the presence of environmental or other known risk factors for cardiovascular disease, such as family history, tobacco use, high fat and sodium diet, alcohol consumption, recreational drug use, and stress at home or work. Specific physical manifestations associated with hypertension are retinopathy, headache, target organ damage like renal disease. Of course, the main component of hypertension is a blood pressure reading of more than 130/80 on two separate occasions. This is not the same diagnostic indicators for hyperlipidemia nor atherosclerosis.
Unfortunately, hyperlipidemia has no physical clinical manifestations other than elevated lipids in laboratory tests. Those patients with primary hypercholesterolemia can have xanthomas and arcus cineus. But these are small portions of the population, and these patients have an LDL-C greater than 100 milligrams per deciliter. Oftentimes, patients aren't aware that they have hyperlipidemia until they've had an atherosclerotic cardiovascular disease event. But as mentioned earlier, hyperlipidemia is a risk factor for cardiovascular disease, so they are very interrelated, and it's important to understand how they affect each other.
Discuss how the treatment for cardiac disorders is related to the pathophysiology of the disease.
Hypertension is directly linked to obesity, diet, and inflammation within the body. Therefore, it's important for the nurse practitioner to discuss lifestyle modifications with patients as the initial treatment plan. Lifestyle modifications are important in reducing blood pressure and comorbidities. Dietary modifications for all cardiovascular disorders include the dietary approaches to stop hypertension, also known as the DASH diet, salt restriction, potassium supplementation, and limiting alcohol consumption. The recommended intake of sodium, according to the American Heart Association, is no more than 2,300 milligrams per day. Reducing that amount to no more than 1,500 milligrams per day for individuals with hypertension is ideal. This recommendation is directly linked to the pathophysiologic process of the pressure-natriuresis relationship. Increased sodium intake causes increased vascular volume, causing a rise in blood pressure. For some patients, both non-pharmacologic and pharmacologic approaches may be necessary for treatment. When deciding on pharmacological treatment, it is important for the nurse practitioner to correlate the pathophysiologic process with the treatment. Let me explain. I spoke earlier about the renin-angiotensin-aldosterone system, or the RAS, which sets off a cascade of events in the initial stages of hypertension. The RAS eventually is associated with end organ effects of hypertension, including CAD, renal disease, cardiac hypertrophy, and heart failure. Prescribing medications such as angiotensin-converting enzyme inhibitors, known as the ACE inhibitors, or angiotensin II receptor blockers, known as the ARBs, and aldosterone antagonists oppose the activity of the RAS and are effective in lowering blood pressure. So these medications not only lower blood pressure, but are considered heart and renal protectant. The 2017 American College of Cardiology and American Heart Association have established hypertensive guideline recommendations. These recommendations include thiazide diuretics, ACE inhibitors or ARBs, and calcium channel blockers as first-line agents to be used in the initiation of pharmacological treatment for hypertension. Sometimes a combination therapy using two drugs is recommended for patients with stage 2 hypertension and for those unable to attain goal blood pressure with pharmacological monotherapy, in addition to the lifestyle changes. Using combination therapy can address two independent factors of the pathophysiologic process of hypertension.
With all three disease processes, hypertension, hyperlipidemia, and atherosclerotic cardiovascular disease. Early prevention is key. Therefore, it's important to identify the patient's ASCVD risk. This can be done by using the Atherosclerotic Cardiovascular Disease Risk Estimator Plus tool found on the American College of Cardiology website. Treatment for atherosclerosis is dependent on the patient's ASCVD estimated risk. Non-pharmacological treatment includes the same lifestyle modifications that Julia mentioned earlier, such as smoking or vaping cessation and increasing physical activity. The nurse practitioner should educate the patient on smoking cessation and offer agents to help the patient quit smoking. The nurse practitioner also needs to educate the patient on exercise recommendations from the ACC and AHA. The current guidelines suggest that adults get at least 150 minutes of moderate intensity exercise or 75 minutes of vigorous intensity aerobic activity every week and perform muscle strengthening activities at least 2 days per week. The goal of initiating statin therapy is to decrease the percentage of LDL-C in the blood. The literature supports the notion of the lower the LDL-C, the better. The treatment recommendations are based on the patient's risk score. Patients with a low or borderline 10-year risk should focus on lifestyle modifications, though patients who are borderline or intermediate risk with risk enhancers should have a discussion between the provider and the patient regarding the risk-benefit of starting moderate-intensity statins. Patients identified as high risk will benefit from the initiation of statins with a goal of 50% reduction or more.
Hypertension, hyperlipidemia, and atherosclerosis disorders are in the top 12 list of diagnoses billed in primary care. So can you speak a little bit about billing for these disorders?
The International Classification of Diseases, 10th revision, clinical modification, what we know as the ICD-10, is a morbidity classification published by a joint effort between the Center for Medicaid and Medicare Services and the National Center for Health Statistics. It is used as the standard billing code system that is used by providers to submit diagnosis codes for insurance reimbursement. Hypertension has billable ICD-10 codes spanning from I10 to I15, excluding I14. The ICD-10 code I10 is for essential primary hypertension and is submitted for individuals who do not have associated cardiovascular or renal comorbid conditions. If an individual has a causal relationship due to cardiovascular or renal disease, the code indicating the type of relationship is required. For example, if a patient has hypertension with systolic congestive heart failure, codes I11.0 for hypertensive heart disease with heart failure and I50.2 for systolic heart failure, both should be submitted. For patients with a single elevated blood pressure reading, the code R03.0 should be submitted until a formal diagnosis of essential hypertension is established. While it is not uncommon for patients with long-standing hypertension to develop renal or cardiac changes, it is important to document the supportive information within the chart. Documentation must always support the billing, so it is imperative to document and code correctly. The NP must recognize that the code with the highest specificity will increase reimbursement.
Hyperlipidemia has 6 billable ICD-10 codes that are appropriate to use in primary care. E78.0, E78.1, E78.2, E78.4, E78.5, and Z83.4. Outside of the E codes is the Z code 83.4, which is used for family history of other disorders of lipoprotein metabolism and other lipidemia. The ICD-10 code I25.11 was used for atherosclerotic heart disease of the native coronary artery without angina pectoris. This code encompasses atherosclerotic cardiovascular disease, coronary artery atherosclerosis, coronary disease, and coronary artery sclerosis. You can build upon the Z code with additional E codes based on the individual patient and including other risk factor codes that are associated with atherosclerosis such as hypertension, diabetes mellitus type 2, peripheral vascular disease, nicotine use, and obesity.
What is the nurse practitioner's role in managing cardiac disorders?
The role of the nurse practitioner in managing cardiovascular disorders includes the initial and ongoing assessment of patients, ordering appropriate labs and diagnostic testing, the pharmacological and non-pharmacological management per treatment guidelines, patient education on diagnosis, lifestyle modifications, and medication. The nurse practitioner should also coordinate care, including referrals to specialists when needed, having timely follow-up with patients, and finally, billing services for reimbursement of care and performance measurement.
Nurse practitioners are an integral part of a team-based approach to care, which contributes to improved patient outcomes. Nurse practitioners help increase follow-up opportunities and maintain a judicious focus on cost-effective treatment. Patient satisfaction with a specified treatment plan and quality of contact with a healthcare professional is linked to medication adherence and compliance with lifestyle behavioral changes.
Nurse practitioners see beyond the diagnosis and follow a more holistic approach to care. A nurse practitioner considers the social, cultural, economic, and behavioral elements of an individual with hypertension and designs a patient-specific treatment plan by being culturally sensitive, examining guidelines, and addressing any relevant social determinants of health. This is one of the many ways nurse practitioners are leading the way to promote change within communities and improve the quality gap and ethnic disparities.
This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer.